Welcome! We're about to do a really important clinical deep dive. Today, we're breaking down the brand new, crucial updates from the 5th edition of the ASRA Evidence-Based Guidelines. These are the recommendations that really shape our day-to-day practice when we're doing regional anesthesia on patients taking antithrombotic therapy. So let's jump right in.
Okay, so here's our game plan. We've structured this to really build your understanding from the ground up. First, we'll talk about the big one, the foundational risk that drives every single decision we make, neuraxial hematoma. Then, we'll quickly review the protocols for those legacy anticoagulants we all know so well, before really focusing on the biggest updates, which are all about the direct oral anticoagulants, or DOACs. After that, we'll cover antiplatelets and some other key agents, tackle a few of those tricky clinical scenarios we all face, and finally, we'll wrap it all up by distilling everything into some core principles you can take with you.
So first things first, let's really get grounded in the why behind all these incredibly detailed guidelines. It really all boils down to preventing one specific complication, a rare one but a potentially devastating one, the neuraxial hematoma. Honestly, if you understand this risk, then the rationale behind every single time interval and recommendation we're about to discuss just clicks into place.
Now, when you look at these numbers, you might be thinking, wow, that's incredibly rare. And you'd be right. The estimated incidence after an epidural is less than 1 in 150,000. For a spinal, it's even less common, somewhere around 1 in 220,000. So why all the fuss? Well, it's the sheer severity of the consequences. We're talking paraplegia, permanent neurologic injury. A hematoma that forms in the tight, confined space of the spinal canal can cause direct cord compression and ischemic injury pretty quickly. And that, right there, is why this meticulous, evidence-based management isn't just a nice-to-have or best practice, it is an absolute necessity.
In this slide, this just lays out the stark reality of the situation. This is classic data from Vandermolen and his colleagues, and it shows this clear inverse relationship between the time to intervention and the patient's neurologic outcome. Just look at this. For patients who get to the OR for surgical decompression within 8 hours of becoming paraplegic, the vast majority have a good or at least partial recovery. But now look at what happens when that delay stretches past 24 hours. The chance of a good recovery just plummets. This is why we say time is spinal cord. It underscores the critical need not just for prevention, but for lightning-fast diagnosis and immediate action if you even suspect a hematoma.
All right, so with that really serious foundational risk in our minds, let's move on and review the guidelines for the agents that we're probably most familiar with. We'll start with what we're calling the legacy anticoagulants, the heparins and the vitamin K antagonists like warfarin. And while yes, the new guidelines put a heavy focus on the DOACs, having a rock-solid grasp of these legacy agents is still absolutely essential for safe practice.
Okay, so this table lays out the established and, for the most part, unchanged protocols for unfractionated heparin. When we're talking about intraoperative IV heparinization, like you see in vascular surgery, the key principle is simply separation in time. This is all based on UFH's rapid onset and really short half-life. The rule is, we perform the neuroaxial block at least 1 hour before we give that systemic heparin dose. This gives us time to make sure the block is working, and crucially, that we don't have a traumatic tap before the patient is fully anticoagulated. For indwelling catheters, they need to come out 2 to 4 hours after the last heparin dose, which gives us a window to assess their coagulation status. And for subcutaneous prophylaxis, while the risk is pretty low, it's always smart to check the patient's platelet count if they've been on it for more than 4 days, just because of that small risk of hit.
Now, for low molecular weight heparin, the most critical point has always been this distinction between the different dosing regimens. For your standard low-dose prophylactic schedules, think once daily dosing, a 12-hour interval is the recommendation. But, and this is a big but, for patients who are on higher therapeutic doses, like 1 milligram per kilogram of enoxaparin every 12 hours, that waiting period gets much, much longer. We need a minimum of 24 hours. This reflects the drug's longer, more predictable half-life and makes sure its anticoagulant effect has sufficiently worn off before we go anywhere near the spine. This longer wait is a really key safety measure because LMWH has a much more sustained anti-XA activity compared to UFH.
Right, warfarin. Managing warfarin is less about a single time point and much more about a multi-day strategic plan. Ideally, you want to stop it at least 5 days before the procedure to give the body time to synthesize new vitamin K-dependent clotting factors. And here's the non-negotiable part. You must check the INR before any needle placement. For moving a catheter, the guideline is crystal clear. The INR should be 1.5 or less. And that's not an arbitrary number. It comes from studies showing that at an INR of 1.5, factor activity levels are generally above 40%, which is considered enough for hemostasis. And of course, for your high-risk patients, like those with mechanical heart valves who need bridging, you just stop their therapeutic heparin or LMWH according to their own specific guidelines before the procedure.
Okay, here we go. Let's turn our attention now to the area with the most significant practice-changing updates in the entire 5th edition, the management of direct oral anticoagulants. These updates are a huge deal because they provide some much-needed clarity and more specific guidance for this incredibly common class of drugs.
The very first and maybe most fundamental change is actually about language, but it has some major practical implications. The guidelines are officially moving away from the terms prophylactic and therapeutic. Instead, from now on, we're using low dose and high dose. Why? Well, because a single DOAC can be used at all sorts of different doses for different reasons. For example, the dose for VTE prophylaxis after a knee replacement is totally different from the dose for stroke prevention and AFib. The old terms could get really ambiguous. This new language is just so much clearer and lets us apply the guidelines directly to the patient's actual prescribed regimen. It's a great change.
And this table just perfectly illustrates the new specific recommendations for apixaban. So for patients on a low dose, which is typically 2.5 milligrams twice a day, apixaban should be stopped for at least 36 hours. But for those on a high dose, usually 5 milligrams twice a day for AFib, that interval gets extended significantly to at least 72 hours. This is a really critical update from previous editions, and it's based on the accumulating pharmacokinetic data and post-marketing surveillance reports of hematomas that suggested the shorter hold times just weren't enough for these high-dose regimens.
The guidelines give us similarly detailed, time-based recommendations for rivaroxaban and etixaban. For low-dose rivaroxaban, it's a 24-hour hold, but you extend that to 30 hours for patients with a creatinine clearance below 30. For low-dose etixaban, it's a straightforward 24-hour hold. But look here, for high doses of either drug, the recommendation is a much more conservative 72-hour discontinuation period. This consistency in the high-dose category actually simplifies our decision-making while putting safety first. And again, it reflects a more cautious approach based on emerging clinical data.
Okay, now dabigatran. Dabigatran management is particularly nuanced, and this is where the new guidelines are just incredibly helpful. Because it's so heavily dependent on renal clearance, the recommendations are now stratified by both the dose and the patient's creatinine clearance. So for a patient with normal renal function on a high dose, a 72-hour hold is fine. But look at the patient with just moderate renal impairment, a CRCL between 30 and 49 on that same high dose. The recommended hold time is a full 120 hours. That's 5 days. This is a massive safety update because even moderate renal dysfunction can dramatically prolong this drug's half-life. And for patients with a CRCL below 30, neuraxial blocks are simply not recommended at all.
So what about reversal agents? Can we just use them to get around these long wait times? Well, this is a crucial point and a new, definitive statement from the guidelines. While yes, we have antidotes like idarucizumab for dabigatran and endosinet alpha for the factor XA inhibitors, the 5th edition explicitly recommends against their routine use just to shorten the wait time for a block. The bottom line is, these agents have their own risks, including potential prothrombotic events, and they really should be reserved for managing life-threatening bleeding, not for procedural convenience.
All right, let's switch gears a bit. Beyond the big anticoagulants, the guidelines also give us some critical updates for other classes of drugs. So let's turn our attention to the antiplatelet medications and some other agents that affect hemostasis. And there's an important update in this section too.
This timeline is a really nice, clear visual summary for the most common antiplatelet agents. So for NSAIDs, and that includes aspirin, the consensus is still the same. They pose no significant added risk, and you do not need to stop them. For the irreversible P2Y12 inhibitor clopidogrel, the recommendation is still 7 days. But here's the key update: ticagrelor. Based on new evidence from platelet function studies showing that function comes back to a safe enough level for hemostasis by day 5, the recommended discontinuation time has been shortened from 7 days down to 5. And for the older drug, ticlopidine, that hold time remains at a much longer 10 to 14 days.
And this table just pulls together the guidance for a few other critical medications. The most significant update here is definitely for fondaparinux. Because it has that super long 21-hour half-life and is completely reliant on renal clearance, the new recommendations are much more specific and way more conservative. For a low 2.5 milligram dose with normal kidneys, you need a hold of 36 to 42 hours, and that extends significantly if there's any renal impairment. As for thrombolytics, the advice is unchanged. Just avoid neuraxial techniques. And for herbal meds like garlic, ginkgo, and ginseng, the guidelines confirm that, by themselves, they don't pose a significant additional risk.
Okay, so theory is one thing, but we all know that clinical practice loves to throw us curveballs in complex, unexpected scenarios. So now we're going to address some of these specific, high-stakes situations and see how these new guidelines can really help us navigate them safely. All right, here is a classic, challenging clinical question that can cause a lot of anxiety on the floor. You've got a patient with a perfectly functioning epidural catheter, and then you find out that a high dose of a DOAC, like apixaban, was just given, either by mistake or maybe for an urgent clinical reason. So the catheter's in, the anticoagulant is on board. What on earth do you do?
The new guidelines give us a really clear two-pronged protocol here. Your first option is simply to wait. You have to withhold any more DOAC doses and delay any manipulation or removal of that catheter for the full recommended time interval. So in our example of high-dose apixaban, that's a 72-hour wait. The second and newer option is to use laboratory guidance if you have it available. You can actually check a drug-specific plasma level, like an anti-factor XA assay for apixaban, and if that level comes back less than 30 nanograms per milliliter, it's considered safe to manage the catheter. But the guidelines are also careful to state that routine testing for all patients is not recommended.
This is so important. We have to remember that these guidelines aren't just for spinals and epidurals. Deep plexus blocks, like a lumbar plexus or a psoas compartment block, carry a real risk of hemorrhage because we're doing them in a non-compressible space. A bleed in the retroperitoneum can collect a huge volume of blood before it ever becomes clinically obvious. And this table highlights case reports where exactly that has happened. So the critical takeaway here is that the new, stricter guidelines for DOACs and fondaparinux explicitly apply not just to neuraxial blocks, but also to deep plexus and other peripheral blocks where the site isn't compressible or where vascular puncture is a significant risk.
Wow. We have covered a tremendous amount of detail, from the foundational risks to all the drug-specific timings and those tricky special scenarios. So for our final section, let's just synthesize all of this information into a set of core, overarching principles that can guide you in your daily clinical practice.
These 4 points right here, this is the bedrock of safe practice. First, every single patient requires their own individualized risk-benefit analysis. We have to weigh the incredible benefits of regional anesthesia against the risk of a hematoma. Second, communication is everything. You've got to talk to the surgeons, the pharmacists, the nurses. Everybody needs to be on the same page. Third, our job isn't done when the block is in. Vigilant post-op neurologic monitoring is our ultimate safety net. And finally, if there's one thing you take away from this 5th edition, it's the adoption and application of the new high-dose versus low-dose distinction for the DOACs. That is the critical update.
And I want to end with this crucial thought, which is a direct quote from the guidelines themselves. These recommendations are meticulously researched, and they're based on the best available evidence we have. They're designed to inform your decisions, to guide your practice, and to make our patients safer, but they are not intended to replace your clinical judgment. Ultimately, the art and the science of what we do lies in applying these principles to the unique, complex, and individualized care of each and every patient we have the privilege to treat.